Hi, this is Roger Green, host of the Surfing the MASH Tsunami podcast. This week, we're offering 5 conversations from episode 4, our review of MASLD epidemiology and disease burden with Zobair Younossi, plus, from the vault, an epidemiology discussion from back in 2022. In this opening conversation on MASLD disease burden, Zobair Younossi summarizes and expands on some key points from the recent Diabetes Spectrum Review article he co-authored with Linda Henry. Zobair starts by discussing the recent review article titled Understanding the Burden of Non-Alcoholic Fatty Liver Disease, Time for Action, which he describes as a summary of large body of evidence that's being generated. He points to 3 pivotal issues. First, the treatment burden associated with MASLD and MASH, which is extremely high and will grow over time. This is true in the general population, but particularly important for patients with diabetes. 2, the humanistic burden, as measured in quality of life scores, is also significant. Patients living with MASLD and MASH report lower QOL scores, which translate not only into personal unhappiness, but also poorer worker performance, seen in presenteeism and absenteeism. Third, the economic burden of MASLD, which is significant, but varies in scale and structure from country to country. In every country, key drivers include dietary issues and inactivity. The major cost burden is driven largely by key downstream sequelae of cardiovascular disease and cancer, both HCC and extrahepatic, which are the leading causes of death for MASLD. Jorn Schattenberg joins the conversation to commend Zobair on his work, which, as Jorn puts it, and I quote, educates us as physicians on where the risk factors and the at-risk populations are, and we're moving that way. I mean, we're trying to focus on patients with diabetes that are more advanced from the hepatologist's perspective, end of quote. Finally, Zobair describes the Markov models of disease cost. His group has already built 7 countries and plans to build in more. Key point, MASLD is costly everywhere, but the structure of cost and, more importantly, public health solutions will vary from country to country. Zobair Younossi has spent decades building a knowledge base that is a significant part of how the world looks at MASLD patient dynamics and trends today. This discussion encapsulates some of that wisdom in the context of winter 2024. It intrigues while it educates. So just sit back, listen, enjoy, learn, and when you're done, join our dialogue in the LinkedIn discussion group.
Zobair Younossi.
I think that this was a review article, which was a summary of a large body of evidence that's being generated. The bottom line are a couple of things. One, that the prevalence of MASLD in the general population globally has increased now to about 38%. So this is a large increase. But if you actually focus on the type 2 diabetics, these are individuals who are at highest risk not only for having MASLD and MASH, but also high risk of having adverse event, including mortality. The latest meta-analysis that we performed, and it's currently being published, is that prevalence for MASLD is 68%. But if you look at MASH, in the general population, the prevalence is about 5 to 7%, and the type 2 diabetics is about 37%. And about a quarter of those patients actually can have advanced fibrosis. So that tells you that the prevalence of MASLD in general has increased, and then among those who have really the most severe form of metabolic disease, type 2 diabetes, is even higher. And both the visceral obesity and type 2 diabetes is increasing across the globe, so these rates are increasing. We've done another meta-analysis that's currently being peer-reviewed, which is looking at the prevalence of MASH cirrhosis globally. And that's also interesting because the prevalence is somewhere between, in the general population, is about 0.3 to 1.8%. So that's a large number of patients when we are looking at this. And the enhanced data set from the United States, the prevalence of NASH or MASH cirrhosis was about 1.8%. Now, if you look at those who already have NASH or MASH, and we look at the prevalence of cirrhosis, of course, that's higher. It's about 5 to 6%. But even in general population, the numbers are pretty large. So that's on the clinical burden of disease. We've also been looking at the humanistic burden of this disease, meaning patient-reported outcome and quality of life. And there is a substantial body of evidence that quality of life of these patients are impaired, which is probably primarily driven by fatigue. We have a paper currently that's actually being resubmitted looking at fatigue in different liver diseases. And in fact, the liver disease, fatigue is a predictor of bad quality of life or other patient-reported outcome. And that's not only important from a patient perspective, but it's also important from a societal perspective, because fatigue is a driver of work productivity or lack thereof, which means that the indirect cost associated with MASLD could be substantial because fatigue drives a lower worker productivity, which results in significant indirect economic loss to the society. Now, that is in addition to the direct cost of MASLD, which is another project we are currently doing and finalizing. So those are the different aspects of the burden of this disease. When you put this in the context of global burden of disease analysis that we've done, it shows you clearly that in most regions of the world, when you look at GBD data, that the prevalence and mortality from MASH and MASH cirrhosis and MASH liver cancer, or HCC, is actually showing an increase in terms of annual percentage change. So every year for over year, MASH is actually increasing. And on the other hand, if you look at, for example, HCC, cirrhosis or HCC, especially HCC, in a lot of regions of the world, the burden from hepatitis B-related HCC is actually declining. So there is improvement, probably related to vaccination and other things. But for MASLD and MASH, they're increasing. And this is also highly driven by both lifestyle of diet, but also inactivity. In fact, our analysis of GBD from Middle East and North Africa suggests that it is driven by, the metabolic risk factors and diet associated with this, but significant inactivity. That's part of lifestyle that needs to be addressed. So lots of things interconnected, clinical outcomes with humanistic outcomes to the economic outcomes. And that what we saw 2 decades ago, when I started in this field, that was almost 25, 30 years ago, we were not aware of the burden. And now we know that it's not just the prevalence that is high, that it actually leads to bad outcomes. And that's liver cancer. Currently in the United States, it's one of the dominant reasons. In fact, the number one reason to be on the transplant list for liver cancer in the United States is NASH or MASH. So it's the second indication in general for liver transplant in the United States, and I suspect in a number of different parts of the world. So this disease's burden is so wide and multifactorial that impacts every aspect of the different types of outcomes we're looking at.
Jörn Schattenberg.
Roger, if I may just say, Zobair, congratulations on the work you've been doing over decades now for this, and really with your team together coming up with a meta-analysis from different parts of the world. I always find that is amazing how you oversee all these different developments. If I summarize it, the clinical burden, I think you help us as a clinician to actually look into the right direction, right? So you educate us as physicians on where the risk factors and the at-risk populations are, and we're moving that way. I mean, we're trying to focus on patients with diabetes that are more advanced from the hepatologist perspective, and we're trying to educate the endocrinologists about the prevalence in their practice, and GPs, on the other hand, helping them with the prevalence in their environment and help to shape patient referral pathways. So I think that's very important. The patient-reported outcomes couldn't be underestimated, because at the end, that's what counts for a patient, right? How do they feel? And you're able to measure that across all these big populations, coming up with meta-analysis data for that. Very impressive. And again, congratulations. The financial aspects are very different from country to country. I know we've discussed in the past a cost of inactivity. So the question is, if we don't act on that highly prevalent disease to a certain level, we're of course continue to incur costs. And I think that's something you also included in some of your models, or you've been discussing with the team. Is that right?
Yes, Jörn, thanks for reminding me of that. That's so important to actually assess and estimate the economic burden in each country based on the reality of that country. So we've been creating a Markov model now for many years that needs to be updated, and the data needs to be perfected as much as possible. So we have a very, very good model at the moment. We've just finished actually assessing the economic burden of MASLD in the United States, where our plan is to actually do 6 or 7 countries, including Germany. Jörn and Michael Roden and Frank Taki are all involved with the German model with us. We go to Spain, we go to Brazil, we go to Saudi Arabia, Japan, potentially Italy, and other countries will come. But I think it'll be important to look at each country, that if you really don't, it's really what I call it is the not only cost of inaction, but what is the economic burden of the disease. And that means that if you don't do anything as a policymaker, the cost of not doing something, just the direct and just some of the indirect costs. The indirect cost that we can measure is work productivity loss, as I mentioned before. That actually is enormous for countries, and the countries need to have policies to address this and promote education about this disease, so that we can, remember, if the prevalence of MASLD is 38%, the number of patients that actually will develop cirrhosis in terms of percentage is relatively small. But because we're dealing with such big group of patients with MASLD, that small proportion still is a huge number of population that we need to deal with. So that is really incredibly important for all stakeholders. In this context, for the policymakers, payers, especially, and payers are different in different parts of the world, to make sure that we address it, that we have policies that will actually recognize MASLD as one of the most important non-communicable diseases that's, outside the infectious diseases that we talk about, but it be recognized as one of the important non-communicable diseases in the world.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put those in the review section of the page from which you downloaded this conversation, or send an email to me, questions@surfingmash.com. We'll be back next week to discuss what new information or product to expect in NIT space in 2024. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.